Well, hello. Thank you for joining me today as we talk about eosinophilic esophagitis. My name is Kevin Ghassemi, and I'm Associate Director for the Center of Esophageal Disorders here in the UCLA Division of Digestive Diseases. Before we go on, I just wanted to let everyone know that they can ask questions through Twitter using hashtag UCLAMDChat. So I'd like to give everyone today an overview of eosinophilic esophagitis. We're going to talk about what it is and how common is it, what are the symptoms, associated conditions, how we make the diagnosis of eosinophilic esophagitis, and potential treatment options including medicines, endoscopic therapy, and dietary elimination. And again, to remind you, you can ask your questions at the end, which I'll answer through the hashtag UCLAMDChat on Twitter. So I will use the terms eosinophilic esophagitis and EOE interchangeably because it certainly can be a tongue twister and a mouthful to talk about. EOE is an immune-mediated condition, and by that I mean that your body's immune system responds to some type of foreign stimulus and leads to inflammation in the esophagus. And when we look at the esophagus under the microscope, we see that this inflammation is made up of predominantly a white blood cell called eosinophils. And eosinophils are frequently seen in allergic types of disorders. We will see it in asthma and eczema, many other allergic types of disorders. Now, EOE by definition means that the inflammation is confined to the esophagus. If you have eosinophilic inflammation elsewhere in the digestive tract, it's a completely different disorder. And the symptoms that go along with EOE are really related to the impairment in esophageal function. Such as the swallowing problems and heartburn that I'll talk about in a little bit. And probably most importantly, this is a benign condition. It does not have any known association with progressing to cancer, but it is a chronic condition and one with which patients must deal with for most of their life. So fortunately, EOE is not extremely common. It affects about 4 out of every 10,000 people, which in a population of 300 million that is in the United States, it's close to 100,000 people. It is increasing in incidence, and we're not quite sure if that's because physicians are becoming more astute and picking it up, or if there truly is an increasing number of patients who have this condition. Looking at it another way, it is implicated in over 10% of people who have trouble swallowing. Compare that to about 10 years ago, less than 2% of patients who had difficulty swallowing were they found to have eosinophilic esophagitis. It is something that's more commonly found in children and young adults. In fact, this was described in children way before physicians recognized that this was an adult phenomenon as well. And it wasn't until 1995 that pathologists realized that the eosinophils in esophagus biopsies of adults could actually be due to something other than reflux, and that's when it became acknowledged that eosinophilic esophagitis can affect adults as well. But although it's more common in young people, it does affect all ages. It affects both sexes, although it tends to affect males more than females. And all ethnicities are potential targets for this disorder. Based on our experience here at UCLA, about 3/4 of our patients are men, and the average age at diagnosis is 34 years old. So there are several symptoms that patients with eosinophilic esophagitis can present with. The most common is dysphagia to solid foods, and so let me define dysphagia. This is a condition where the patients will sense that food does not travel down very well. And trouble swallowing can be related to either a problem with transferring food from the mouth down to the esophagus, or it can be a problem with food being passed through the esophagus and down to into the stomach. So dysphagia in eosinophilic esophagitis is esophageal related. So patients typically will feel that food does not move through the chest very well. Sometimes they may feel like it temporarily gets stuck. And it's solid foods. The most common ones being reported are meat, bread, rice, and in general rough textured foods. But I could tell you that patients have complained of other foods getting stuck, including vegetables, and pasta getting stuck too. So really any consistency of solid food can get stuck in the esophagus. Now, if the food does not pass through, despite several attempts to drink water and have it pass down the esophagus, or to try to regurgitate or vomit it up, this is called a food impaction. And frequently, patients who have a food impaction may need to go to the hospital to have an endoscopy, or a camera-based test that goes through the mouth and down to the esophagus, where the food can either be gently pushed down into the stomach or it has to be removed and pulled through the mouth. Other symptoms that patients may complain of are heartburn, which is typically seen in patients who have acid refluxing up from the stomach to the esophagus. But a minority of patients with eosinophilic esophagitis will experience this symptom as well. Chest pain is also reported, as is abdominal pain, usually in the upper abdomen. And in younger children, we will see them present more with vomiting rather than the other symptoms that I mentioned up here. And infants are typically found to have poor feeding, so they may spit up a lot more frequently. So how does this happen? Well, as with most conditions in medicine, there's probably multiple factors. We think that there may be some genetic predisposition, but regardless, there's some type of allergen, and an allergen is something in the environment, mainly food in this case, but sometimes allergens in the air can cause this problem as well, potentially. And what happens is it leads to inflammation and subsequent scarring. This is not a typical food allergy where if you eat some food that you're allergic to, you get throat swelling or a rash or itching. What ends up happening is the allergen exposure occurs, some type of food, and that leads to inflammation of an eosinophilic type. Over time, scarring will occur. We call this fibrosis. And then finally, the result of that is that the trouble swallowing or dysphagia occurs, or a food impaction may occur. So frequently patients will say, well, if I'm eating meat, does that mean I'm allergic to meat? And the answer is probably not. So we find that because this is an allergic condition, other allergic conditions are found in these same patients. And people with EOE are more likely to have asthma, up to 70% of people. Allergic rhinitis or nasal allergies are found in 3/4 of patients. Eczema, which is a skin condition that's allergy mediated, is found in up to 60% of people. We also find that if we do blood testing, patients' eosinophil counts in the blood are elevated. About half of these people will have that. They're more likely to have the more classic food allergies where they have the immediate swelling of the throat or difficulty breathing or rash or itching. And patients may report medication allergies as well. The diagnosis really comes down to undergoing an upper endoscopy and taking biopsies. So if someone comes to see me in the clinic and says that they have trouble swallowing, particularly solid foods not going down very well, I'll tell them that they need to have an upper endoscopy so that I can look to see if they have the typical visual features of EOE. And biopsies will need to be taken to see if there's an increase in the number of eosinophils in the esophagus. So we take biopsies from several places along the lining of the esophagus. This is not a full thickness removal of the esophagus, but just the surface. And it's recommended that you take at least 2 to 3 biopsies from the upper and from the lower esophagus, because this can be a more patchy disease, and if you just do 1 or 2 samples, you have a lower chance of actually picking up the diagnosis. The number of 15 eosinophils per section under the microscope when we look at it under high magnification is somewhat arbitrary, meaning that people who have eosinophils above 15 may not necessarily have eosinophilic esophagitis. And there are rare cases where less than 15 eosinophils may be found, but they truly do have EOE. But that's the general clinical guideline, to have at least 15 eosinophils per section under the microscope. And it's also recommended to take biopsies from the stomach and the small intestine, just a couple at least, to make sure that there's no inflammation of the eosinophilic type in the stomach or the small intestine, which would then make this a different diagnosis. So I want to show you some pictures of what we might see as gastroenterologists when we do the endoscopy. The most common finding are what we call concentric rings. And so this is a very marked example where you see these rings that occur all the way around. Well, I can't really draw very well on here. But here's a very strong example. And you can see here there's just subtle examples of little rings across that go down the length of the esophagus. So that's the most common finding. Another finding are what we call linear furrows, which, I'll give this another try, go down the length of the esophagus like this. And you can see this example also, they have the rings here. Another finding, which is a little bit less common but interesting nonetheless, is what we call felinization. Now, felinization comes from the idea that this picture right here is what we see if a cat has an endoscopy. And this is something that occurs temporarily and then can go away, almost like an accordion collapsing and then expanding. And then finally, the most feared or end stage complication that we can see during the endoscopy in eosinophilic esophagitis is an esophageal stricture. Notice that this is much smaller caliber compared to the openings here or really in any of these other pictures. And when that occurs, patients are much more likely to have a food impaction because it just won't pass down. And this is going to need more definitive therapy to open up the diameter of the esophagus. Problem is, none of these endoscopic findings are specific for eosinophilic esophagitis, so we can't rely on the pictures alone. We have to take the biopsies and find that there's increased eosinophils present, as I mentioned. But then it becomes a diagnostic challenge because there are other conditions that can cause eosinophils in the esophagus. And the big one that is even more common than eosinophilic esophagitis is GERD, or gastroesophageal reflux, or more easily known as acid reflux. And when the first guidelines for adult eosinophilic esophagitis came out in 2007, it was thought that these had to be two distinct entities. You couldn't have one and have the other. So if you were going to diagnose someone with eosinophilic esophagitis, you also had to make sure they didn't have reflux. And you could either give them a trial of acid-blocking medications called proton pump inhibitors, which we'll talk about in a little more detail later, and they had to fail, have no response to that. Or they had to undergo formal reflux testing to see if there was acid reflux coming up in excessive amounts. But now we know that the two disorders can actually coexist, either as two separate problems occurring in the same patient, or the reflux being a consequence of the eosinophilic esophagitis. As I mentioned, there can be impairment in the movement of the esophagus, and one of the ways in which reflux can occur is if the esophagus doesn't work well, so it can't clear the acid out of the esophagus that is trying to come up. But what makes things even more confusing is that just a couple of years ago, researchers found that there was this concept called proton pump inhibitor responsive esophageal eosinophilia. That has a mouthful, otherwise known as PPIREE. And in this case, you have patients who have typical symptoms, typical endoscopic findings. They have more than 15 eosinophils per high-powered field. And yet, if you put them on a proton pump inhibitor, their symptoms go away, the eosinophil counts go down. And the researchers found that patients who even had normal reflux testing beforehand, meaning that they didn't have reflux, still had a response to the proton pump inhibitors. So this entity of PPIREE has become another interesting or complexity of the diagnostic mechanism for making the diagnosis of eosinophilic esophagitis. Before we get on to more of the treatment, I just want to talk about the role of an allergy evaluation. So most of my patients will say, do I need to see an allergist? Or they may have actually seen an allergist first because they noticed that particular foods were getting stuck in their esophagus. And we do recommend an allergy evaluation, but not really because of the eosinophilic esophagitis itself. It's actually because there is such a high rate of other allergic disorders, and we want to make sure that patients don't have a risk of a more immediate type of allergic reaction where their throat could close up or they may have trouble breathing. The testing, though, that's done there is either of a blood type called IgE, which I'll talk about a little bit more in a few minutes, which is found in the more immediate types of reactions. And then they can also do skin testing, whether it's called skin prick or patch testing. The problem with these tests is that with regard to making the diagnosis of eosinophilic esophagitis, or even identifying which food or foods may be associated with it in a particular patient's case, it's not very good. Maybe only about 10 to 15% of people can we actually identify the cause of the eosinophilic esophagitis by way of allergy testing. So now I'd like to move towards the treatment options, and because of this concept of PPI responsive esophageal eosinophilia, what we first recommend in terms of treatment is to use a proton pump inhibitor, or PPI for short. And I've listed all the different ones that are commercially available. These are their generic names. You may be more familiar with the brand names that are in the parentheses. In fact, the first three are now available over the counter without a prescription. The way that these work mainly is through acid suppression, but there was an interesting study done on esophageal tissue where it was removed from the stomach. So this was a bench work-based lab test, and they found that the proteins that are expressed when there's when there's eosinophilic inflammation were increased in people who had eosinophilic esophagitis. Yet when the tissue apart from the stomach was treated with something like omeprazole, the inflammation actually got better. So there was no stomach acid involved, and yet the inflammation went away, suggesting that these proton pump inhibitors may have anti-inflammatory properties in addition to their acid suppression capabilities. And it's found that about 33 to 50% of patients who are treated with a PPI, who have the diagnostic features of eosinophilic esophagitis, will get better. And so it's recommended that all patients who are diagnosed with eosinophilic esophagitis should first be treated with an 8-week course of a proton pump inhibitor twice a day to see if they actually have this PPI-responsive esophageal eosinophilia. The one difference from among these medications is this last medication, dexlansoprazole, which actually functions like a twice-a-day medicine, but only needs to be taken once a day. So it's still twice a day in effect. Now, if patients don't respond to the proton pump inhibitors, the mainstay of treatment ever since this condition was identified in adults was to use a topical steroid. This is not the anabolic steroids that you hear about with baseball, for instance. It's more of the anti-inflammatory type. And there are two types that we use that act in a topical or on-the-surface nature. One of them is through an inhaler, and the main medicine there is called fluticasone. So instead of inhaling the medication, which would make it go down the lungs, we have the patients depress the canister, and it puts out a puff of the medicine into the mouth, and you have the patient swallow instead. And so the goal is to get this medication down into the esophagus, and it'll just coat the esophagus. That medication is used in 2 puffs in the morning and 2 puffs in the evening. The other option is a viscous preparation, and that medicine is called budesonide. And budesonide actually comes in a liquid form, but to make it viscous, the people who studied this medication mix it with Splenda, which is a sugar substitute. Now, can another sugar substitute be used? Probably, but it just hasn't been tested. Could regular sugar be used? Probably again as well. It's just to mainly make it a more viscous preparation. Probably the people who were studying this, they just wanted to not add extra calories to the diet. Now, both of these medications, as I mentioned, are used twice a day, and we do it for about 2 to 3 months to really see if there's an effect. These medications have been shown in studies to reduce the eosinophil counts, to improve symptoms, and also may actually make the scar tissue go away, although that's a little bit more debatable. The way that the patients will take this is usually after breakfast or after dinner, because you don't want to have anything to eat or drink about 30 minutes after using the medication. Otherwise, it may just wash it down into the stomach, and then it really won't have much effect. I do recommend that patients will take a little water to gargle and swish around in their mouth and then spit it out, just so that any residual medicine is not left behind. And the main reason for that is because there are some side effects with this medication. The most commonly identified, although not necessarily a very common side effect, is that you can get a yeast infection in your mouth called thrush. And that seems to affect about 1% of patients using these medications. And in studies, patients who underwent an endoscopy later on, about 5% of them had yeast found in their esophagus, yet they had no symptoms whatsoever. And so this is probably not a significant finding, but it still was identified in these patients who underwent the follow-up endoscopy. In rare cases will we need to use oral steroids, and this has a much more systemic effect, but it may be more potent and useful for people who do not respond to the topical steroids or who need rapid improvement in their symptoms. The main medicine that's used here is called prednisone, and prednisone is very powerful. It's a good drug, but it also has a lot of side effects, and that's why it's not commonly used. I've listed a few here, including weight gain, a sense of agitation and trouble sleeping, otherwise known as insomnia. You're more susceptible to infections if you're using this medication long term because it does suppress the immune system, and it can elevate blood sugars, and long-term use has been implicated in causing diabetes. There are also many more which I won't get into. Now another more medical option, although this is not actually involving the use of a medicine, is to treat with dietary elimination. It seems that most patients, we can identify a food that is the cause of the problems. And it's usually some type of protein that stimulates the immune response. So what has been used actually in young children for quite some time has been something called an elemental diet, which is really just made up of amino acids. And amino acids are the building blocks of protein, and in their individual form, they're not likely to stimulate the immune system. It's very effective. Well over 95% of people who are on an elemental diet and have eosinophilic esophagitis will respond to this treatment. The problems are that it's costly, number one, and number two, it just doesn't taste very good. So it may be very hard for adults to use. And even children, a lot of them will have a feeding tube placed to administer the elemental formula so that they don't have to experience the unpleasant taste of the formula. Because allergy testing isn't completely useless for diagnosing eosinophilic esophagitis, it's thought that if you do skin testing, for instance, you can identify a small fraction of the patients where we can predict what the food is that's causing the problem. But again, it doesn't seem to be very predictive, and so it's not something that's routinely done. The concept that's really gained the most momentum, even just the past few years, is what's called a 6-food elimination diet. And this takes the 6 most common allergenic foods, which include wheat, dairy, soy, nuts, egg, and seafood, and you cut them out of the diet. And in the line that talks about the different foods, I say also it includes the milk protein. So this is not a lactose problem. It's actually a milk protein problem. So things like casein and whey have to be excluded from the diet as well. Studies have actually shown that there can be anywhere from 64 to 94% resolution of the problem. That range really is due to how you're really assessing the response, whether it's based on symptoms or microscopic appearance or even just the endoscopic or the visual appearance. And because it seems to be so effective and is a non-medicinal way of treating this disorder, it is accepted as a first-line treatment for eosinophilic esophagitis. So how does this diet take place? Well, as I mentioned, you want to avoid those six food groups for about 6 weeks. And then you want to assess if you have met the appropriate endpoints, which include resolution of symptoms, improvement by endoscopy, such that the rings you might see are going away. And also you want to make sure that there's a reduction in the eosinophils in the esophagus. And if you meet those endpoints, then what you do is one at a time you reintroduce one of those food groups that you had cut out. And you do it on average every couple of weeks. And if you have a recurrence of your symptoms, then that's probably one of the triggers for the eosinophilic esophagitis. And in the landmark study that really made the 6-food elimination diet a good option, they found that wheat was the most common at 60%, dairy was 50%, soy and nuts were 10% each, and then eggs made up about 5%. So actually no one in the study seemed to have a problem with seafood, so maybe it's really only a 5-food elimination diet that was needed. However, this is not really an easy treatment option. Number one, some patients may not have symptoms so frequently such that they may need to be on the 6-food elimination diet longer before they really are able to say that the endpoints were met, at least from a symptom standpoint. Also, if the symptoms don't occur very frequently, when you reintroduce each food group, it may take more than just 2 weeks for you to really identify that the symptoms have come back. Furthermore, as the study suggests, there's still about 35% of people who may not respond to this 6-food elimination diet. Why is that the case? Well, maybe there's another food. Some studies have suggested either rice or corn or legumes such as lentils and beans could be the responsible food. Maybe there's an aero allergen, something in the environment that you breathe in that's causing the problem. And furthermore, it's a time-consuming process. So what if you go through the 6 weeks of the food elimination diet and you don't experience any resolution in your symptoms? In a way, you're still at square one. It also can be very difficult to eliminate 6 different food groups from your diet all at once. Now recently, the researchers who introduced the 6-food elimination diet looked at a 4-food elimination diet. So they actually allowed eating nuts and seafood. And they found that the response rates were still pretty good if you cut out the wheat, the dairy, the soy, and the eggs. Now, as I mentioned in the last slide, 50 to 60% of patients were allergic to either wheat or dairy. So maybe you should just go where the money is and cut out just the 2 major food groups. And in most cases, you might still be able to identify the culprit or culprits. I just want to mention a few other medical therapies for those of you in the audience who are pretty savvy on this condition and have heard of these treatment options. There are leukotriene inhibitors. The most commonly one known is Singulair, also known as Montelukast. And there was only a small study of 8 patients. And of these 8 patients, 7 responded to the medicine based on symptoms alone. They didn't have any follow-up with regard to endoscopy or further biopsies to look at the eosinophil counts. Furthermore, they had to use doses that were up to 100 milligrams of the Singulair, which is 10 times what is normally given for other allergic conditions. And I've had problems trying to get 20 milligrams approved by an insurance. So it's not something that is easy to do, and it's also not something that is well documented that it actually has a benefit. So therefore, the Gastrointestinal Society guidelines do not recommend it as a treatment option for EOE. The area of most heavy research nowadays is with antibody therapy. And antibodies are proteins that are supposed to attack other inflammatory proteins to help reduce inflammation. It's also used in cancer to help kill cancer cells. So it's a very intensely researched area right now. And there have been some allergic-related antibodies that have been developed. One is called interleukin-5, or IL-5 for short, and the ones used are called mepolizumab and reslizumab. More tongue twisters. And these have been shown in studies to reduce the eosinophil counts, but patients really didn't notice any improvement in their symptoms. So while this may be a potential area, it still needs to be better studied, and maybe there's other inflammatory proteins that can be targeted instead. Just to mention another one called omalizumab, which works on immunoglobulin E, or IgE, and this is a special type of antibody that's found in allergic conditions. Really, studies found that this was very ineffective, and one could gather that that would have been the case based on the fact that allergy testing that involves testing for IgE levels tends not to predict the cause of EOE, and so therefore it probably was not going to work very well in terms of a treatment option. All right, well, I'm an endoscopist, and so one thing that we can offer to patients in certain situations is to dilate the esophagus, which basically will stretch the esophagus open to break up the scar tissue. This is really useful if there's a stricture that's very tight and we want to give the patient more immediate relief, so we can stretch the esophagus a little bit. Now, the guidelines generally recommend that medical therapy be tried first, whether it's dietary or steroids, and of course you try the proton pump inhibitors before all else. But this still can be used even if patients haven't been on medical therapy beforehand. For instance, if you're trying to make the diagnosis the first time they present to you and you see a very tight stricture, I'm going to stretch that esophagus open to at least give the patient a running start, so to speak, so that they at least have some immediate relief of their symptoms, and then we can talk about a more long-term therapy to keep them from getting into trouble again. Some of the downsides of this intervention are, number one, it doesn't treat the underlying inflammation. All it does is break up scar tissue. So if you just do the dilation and then send the patient on their merry way, they're going to come back at some point in time because the inflammation is going to lead to further scarring. And any procedure is not without its risks. So most people after a dilation will feel some chest pain, and that's usually just because the scar tissue is broken up, and so people will feel some discomfort, particularly when they try to swallow. But that resolves typically within 2 to 3 days and is usually not so severe that they need to be hospitalized or have pain medications to keep the pain under control. Bleeding is always a risk when we're doing a dilation, but in the medical literature, only one case was there such a significant bleed that the patient needed to be hospitalized and get transfusion of blood products. Probably the most scary risk, and fortunately the most rare, is what's called a perforation, which is a full thickness tear through the esophagus. And this is something that could be life-threatening. It's fortunately very rare, reported in only about 0.3% of patients having dilations done in academic centers. And while a surgery sometimes may be needed to help close the defect, sometimes patients need to be just hospitalized, kept in such a way that they're receiving nutrition through an IV as opposed to taking it by mouth, maybe getting antibiotics also to help prevent any infection until this perforation heals up on its own. Now, this is a chronic condition, just like any other real allergy disorder. And so whatever you do to treat the condition, if you stop the therapy, the symptoms are likely to come back. And in patients who were treated with the steroids, over 90% of them relapsed, meaning that they had symptoms occur again within 9 months. And so the concept of maintenance therapy has been proposed for treating eosinophilic esophagitis. And this is something that's a relatively new concept, only occurred in the past few years. Initially, the concept was treat with steroids, because that was the only thing available at the time, for 3 months, and then stop. And whenever the symptoms come back, you treat again for another 3 months. Now we know that for people who either have high-grade strictures or who are frequent relapsers, maintenance therapy may be very appropriate. And topical steroids have been studied for long-term treatment, and at a dose that's about 25 to 50% of the starting dose, it seems to do a decent job of keeping the inflammation from coming back. Now, if you do the dietary elimination therapy, really that is a lifestyle change, and it should be a lifelong change. So that's maintenance that's built right into the program. And I spent a little time just a minute ago talking about how if you just dilate and send the patient home and without any other type of medical treatment, they're probably going to have symptoms again. But it actually has been proposed that you could just dilate the patient and they come back as needed for dilations, so long as it's not too frequent. For instance, if the patient has symptoms maybe every couple of years, it may be easier just to do the dilation than for the patient to have to take a medication every day or cut out a food that they love for the rest of their life. So it's just an option, not necessarily something that I highly recommend, but something to consider in terms of maintenance. So this is my last slide. The question that really comes out is, well, what's the right treatment for me? And the answer is it varies. There's really no single treatment that works well for everyone. And what I typically recommend to my patients is that based on the guidelines, we should make sure that this is not a PPI responsive condition. And so I will treat them first with PPIs, again, so long as they're willing, because I'm not going to force pills down their throat. I talk with them about every treatment option at that first visit once the diagnosis is made, and I mention to them about dietary elimination. And really, the dietary elimination is best suited for people who are really motivated to do it. If they don't think that they can cut out the food and make it a lifestyle change, I'm really not going to push that aspect. But if they are interested, I will send them to a nutritionist, and we have a great nutritionist here at UCLA who talks with them about using the 2-food elimination diet, which we've modified with the dairy and the wheat. And I've had a few patients who've decided to go that route, and they've done very well with it. But again, you have to be motivated. Really what it comes down to is you need to discuss this with your gastroenterologist, and he or she will discuss with you the options, the pros and cons, and together you can make a decision about what's going to be right for you. So I think with that, I'm going to wrap up. I again remind you that you can pose your questions through Twitter at #UCLAMDChat. And so we already have some already. So can eosinophilic esophagitis be seasonal? That's a great question. And actually, there is a study that showed that there was some seasonal variation, and it seemed to be in the more spring and autumn months in particular that the diagnosis of eosinophilic esophagitis was made more commonly. One caveat about that is symptoms can occur for years before patients seek medical care. So it's really hard to determine whether if the condition began in a certain season of the year. But one may think that if you're out and about during the months that you're not kind of shut in because of snow or bad weather, you're more exposed to environmental allergens in the air, and that could increase the chances of developing this disorder. So the answer is there may be a seasonal variation in reality, but it's unclear as to why that's the case. It hasn't been proven why. Okay, so the next question is it possible that EOE is related to asthma? I have come to think that my child's EOE is more environmental than food allergy. Another great question. When you're developing inside mom, you actually start with having one tube that then buds off into two branches and becomes the trachea, or the breathing tube, and the esophagus, or the food tube. So it's quite possible that there may be some penetration of inflammation from the respiratory tract to the esophagus. That is certainly a possibility. Of course, it hasn't been proven, but one can always speculate. And in the same regard, it could also be that you just are more prone to allergy exposure, and that's why you can have allergic complications in one area as well as another. So again, a great question with regard to that. There may be some validity to that. Is there an increased chance of having another child with eosinophilic esophagitis if you already have one child with this condition? Okay, well, there were some early studies looking at the epidemiology of eosinophilic esophagitis, and there did seem to be some clustering in families, meaning that if one family member had the condition, another family member also may have had the condition as well. And it could be that there are genetics involved. Genetics seem to have a role in pretty much every chronic medical condition that there is. But you also have to consider that families are going to live in the same environment. They're probably going to eat the same food. So they're going to have the same exposures. And in terms of what's the risk of developing eosinophilic esophagitis if you have a family member or a sibling who already has it, it's not quite clear. In fact, there really aren't great epidemiologic studies or statistical studies that show how commonly or how much more common it is to be found clustering in families as opposed to just sporadic cases where only one family member has it. Okay. So what are the long-term effects of eosinophilic esophagitis? Great question. And the answer is there's probably nothing so serious where, for instance, you're going to develop cancer, as I mentioned, I think, in one of my first slides. The inflammation could either just stay the same way that it is, whether or not you are treated. We don't know that for sure. It could potentially get worse. And I actually have a colleague who has an 80-year-old woman who, because of long-standing and untreated eosinophilic esophagitis, it just became a very narrow caliber esophagus the entire way through, calling it a rifle barrel. And really no medicine there is really going to help make the problem better, and so this patient just gets dilations every so often. And then the other possibility is that maybe over time the inflammation may die down. There are people who have asthma, for instance, that outgrow it when they become adults, for instance. And so it's possible that the inflammation in EOE could just die down as time goes on. Problem is, it's almost like a third can go either better, a third can go worse, and a third can really just have no difference. And there's really no predictive factors that we've identified to help determine who is going to go down which path in the long term. Is eosinophilic esophagitis a genetic condition? If I have it, can other family members get it? I kind of discussed this, but just to hit the point home a little bit more, it probably is in some regard. there is a gene called eotaxin 3, which isn't too important for the purposes of this discussion. But it was found that this gene is much more highly expressed, meaning it's more active in creating inflammatory proteins than someone who doesn't have eosinophilic esophagitis. Now, that protein may be more common because of the inflammation itself, or it may be that that protein predisposes someone to eosinophilic esophagitis. We don't know for sure, but in all likelihood, there is probably some genetic predisposition. Is it safe to use PPIs long-term to treat this condition? This is another great question. PPIs, again, proton pump inhibitors or acid-blocking medications, have been much more commonly used for acid reflux. And a lot of patients will come to me saying, you know, I don't want to have to take a medicine lifelong, especially because I've heard that maybe it can cause bone density problems. And PPIs are thought that maybe they can reduce the bone density and lead to something called osteoporosis, or eventual breaking of the bones. And the thought is that you need an acidic environment in order for calcium to get absorbed. And if you're using a PPI, it's going to lower the amount of stomach acid present, it's going to be less acidic, and therefore the calcium may not get very well absorbed. And over the long term, the lack of calcium absorption or the reduction in calcium absorption will lead to more brittle bones and a bone fracture. Well, that actually hasn't been proven true in terms of the PPIs causing osteoporosis. There's only been studies that suggest that there is an association between taking PPIs long-term and being at risk for fractures. And I could probably quote just as many studies saying that there is no association as the number of studies that say that there does appear to be an association. So it is a theoretical risk. There is a potential mechanism in place. And what I tell my patients is, if you really need to be on the medication and it works for you, then there's really a good indication to continue using it. And furthermore, if you're worried about that potential mechanism for osteoporosis, you can take a calcium supplement, particularly calcium citrate, which doesn't require much of an acidic environment in order to be absorbed. So you can overcome that potential mechanism for the brittle bones by taking calcium citrate. So again, if you need to be on a PPI, and it works for you, then it probably is something you want to stay on. But again, discuss it with your doctor because it depends on how well it works for you. How often should I have an endoscopy for this condition? That's another great question because the real answer is we don't know. If you're a patient who has eosinophilic esophagitis and your symptoms didn't occur that frequently to begin with, and you're taking a medication and your symptoms have resolved, one could argue that you don't really even need another endoscopy because the medication has done its job. What I typically recommend for patients is an endoscopy should be performed if you're not responding to the current therapy. Rather than just switching to something else, we want to make sure that have things progressed, maybe a stricture or narrowing has developed such that we need to treat that to help move forward with the next step of therapy. Some have argued that if you are doing the dietary elimination study, after the 6-food elimination has been performed for at least the 6 weeks, an endoscopy be performed to document that there actually is endoscopic and microscopic inflammatory improvement. But that's been something that's really only been done in a research setting, and in fact that research study that looked at the 6-food elimination diet, these patients were getting endoscopies at the 6-week mark and then every 2 weeks after a new food was introduced. Now that was done mainly to prove the concept, but in real life you're not going to be able to get away with getting an endoscopy every couple of weeks. I don't know of an insurance that will authorize it, first of all. But second of all, it's really inconvenient to have to do that so many times and so frequently, and we don't know that that truly will improve outcomes or makes much of a difference. All right, can a gluten-free diet treat this condition? That's actually a very great question because there have been some studies that have suggested a link between celiac disease, which is the condition where a gluten-free diet is necessary for the condition to improve, and eosinophilic esophagitis. Now, the association is small, but it is, there were higher numbers of people who had eosinophilic esophagitis who had celiac disease compared to the general population. And the opposite was true. people who had celiac disease were more likely to have eosinophilic esophagitis than the general population. Now, there's some flaws in that potential association. The immune-related mechanism is actually different between eosinophilic esophagitis and celiac disease. It involves something called helper T cells, but these helper T cells are actually different between the two conditions. So the pathways are a little bit different, and it's hard to say for sure that there truly is a link. With regard to cutting out gluten, it may or it may not help. And we think that it's actually probably because if you're cutting out gluten, then in effect you're cutting out wheat. You're also cutting out barley and rye, but really the main thing is wheat. And so if you were wheat sensitive with regard to eosinophilic esophagitis, then a gluten-free diet would actually be helpful for you. But it's probably not that gluten is the true problem in this condition, because if you just cut out barley or rye, it may not necessarily make things any better. So it may help, but the link between the two is not very strong, such that I wouldn't necessarily recommend that you cut out all gluten-containing foods, really just wheat, if you want to go down that dietary elimination route. So I think that's all the questions that we have. Oh, we have another one. Get a refresh there. All right, thank you. All right, here's another question. My mom has dysphagia. Again, dysphagia is trouble swallowing. The liquids go right down into her lungs. She swallows thicker stuff, but it sticks in the throat. Any recommendations? Okay, well, I can first say that this is probably not eosinophilic esophagitis, but just to comment on the symptoms that you're reporting with regard to your mom, if liquids are going right down into the lungs, it suggests that the dysphagia is really limited to the oral cavity and transferring the food or liquid down into the esophagus. And this could suggest a weakness of the muscle or some kind of lack of coordination. And we can see this in a whole variety of conditions. It could be because of a stroke. It could be because of maybe radiation if there's a history of cancer to the head and neck. In some cases, we can see people who have had long-standing acid reflux lead to a stiffening or a thickening of the sphincter muscle that's at the top of the esophagus, called the upper esophageal sphincter. And if that occurs, it's not going to open up well for the food and liquid to go down, and instead it can go down the wrong pipe. So, I mean, these would be some thoughts, but I would have your mom talk to her doctor. They may need to do some special x-ray test to see how the food and liquid goes down. But I can tell you that based on that description, it's not eosinophilic esophagitis at the very least. Okay, anything else? Okay, well, I think that's it. Again, thank you everyone for attending this webinar. You can always find out more about eosinophilic esophagitis, or you can see one of our doctors here at UCLA if you are interested. Our website is gastro.ucla.edu. You can also find us through uclahealth.org. Thank you very much, and have a good day.